Good afternoon, everyone, and welcome to Dräger webinar on airway pressure release ventilation. I would like to welcome you all and thank you for your participation today. So today we have a guest of honor and an invited speaker, Dr. Niklas Larsson, who will be delivering his lecture on the airway pressure release ventilation and his experience on how to best optimize these ventilation modes in order to reach the ventilation strategies. Before we start, I would like to first go through some of the organizational topics. So first of all, I would like you to ask to use the raise the hand button to notify us whether you can clearly hear us and see the screen. So the raise your hand button is on the left-hand side on your GoToWebinar portal. Okay, so it seems like everyone can hear and can see us. That's very good. So a few, again, organizational topics. Dr. Niklas will be doing his lecture, and then we will have enough time to answer your questions. In order to ask your question, please type them into the chat box. And at the end of the webinar, we will try to answer as many questions as possible given the time. So again, if you have any questions, please type them into the chat box. And I think without further ado, I would like to, first of all, introduce our speaker today. We welcome Dr. Niklas Larsson from the Umeå University Hospital from Sweden. He has done his studies in medicine at the Umeå University, and he has also completed his residency there. And since 2013, he has been working actively in the intensive care units in Norrland University Hospital in the north of Sweden. And Dr. Niklas is particularly interested in the mechanical ventilation, and he is basically leading the hospital ventilation group and trying to move APRV into their standard hospital treatment and standard hospital practice. And since April 2019, he has taken on a new role as the Chief of Anesthesia, Operations and Intensive Care at the Norrland University Hospital. So I would like to welcome Dr. Niklas Larsson, and I'm happy to have you today, and hopefully we have a very interesting webinar today. So thank you.
Okay, thank you very much, and thank you also for the opportunity to talk about my absolutely favorite topic, airway pressure release ventilation. I've been using APRV in our clinic since 2015, and when I talk about APRV, I mean it in the way that it's described by, among others, Nader Habashi. And just to be clear, this is a screenshot from our old ventilators that we used to have up until a couple of years ago. And this is like the standard setting that you would be offered when you started the mode APRV, with a fairly short T-high, a much longer T-low, a high, or well, a moderate P-high, and like 5 of P-low repeat. And I would just like to be clear that this is absolutely not APRV. I mean, even though it says so on the ventilator, it is something quite different than what we will talk about today. This is just simply pressure control ventilation. APRV will look like this. It consists of a continuous CPAP phase interspaced by very short releases where the CPAP pressure is released. And as you all understand, because it's CPAP, it gives the patient the opportunity to continuously breathe without any synchronization, because we do not have pressure support. So on this screen here, you can see the pressure tracing, where you have the high pressure level interspaced by the short releases, and on the lower on the flow chart here, you can, or the the flow tracing. You can see the spontaneous breathing as the gray breaths here, and then you have the exhalations that are delivered by the releases, followed by inhalation as the CPAP is reapplied. And in between that, the patient can breathe by themselves. So this is central for APRV, because if you do not set up the ventilator in a way that will give this type of appearance, you simply do not do APRV, even if the ventilator says so. And this is a major problem in the science, because a lot of published reports saying that they have used APRV, well, simply you don't have it set up like this, and then you can't say that this is what you studied. So you have to be, when you read the science, really particular about looking into if they've set it up the way we are interested in. So first of all, some basics. When we do APRV, we want at least 90% of the breathing cycle to be in Phigh, or with the lung fully expanded. And this is because all the magic, everything good happens at Phigh, and we will come back to that. But one of the main things about the magic here is that you actually get diffusion of gases as an adjunct to convection. That is, with the lung expanded during the Phigh phase, you will have diffusion of carbon dioxide into dead space air, as well as diffusion of oxygen the other way. But the main problem is usually carbon dioxide elimination. And this is something very important, because it means that you will actually have a reduced demand on minute ventilation. So if you all learned the alveolar ventilation equation, or at least I did when I was a resident, that is suddenly not quite correct anymore. You can, in some circumstances, see that you can, even though you actually reduce alveolar minute ventilation, you can increase carbon dioxide elimination. And this is because the diffusion is so extremely important. And to me, this is not just theoretical, but because I've actually seen it in practice. And I think that this may have a real benefit for the patients, because I firmly believe that a diseased lung will benefit from not having to move as much. I mean, regardless of how you view VILI, you will probably have less ventilator-induced lung injury if you have less ventilation. So I'm thinking that this may be a very important mechanism for lung protection. If we go on talking about lung protection, Nader Habashi has done a lot of work on how the lung moves and what tidal volumes are safe. And his main idea is that really you don't have to pay much attention to the tidal volume, not even in ARDS patients, because you will not have the same type of movement in APRV as in conventional ventilation. Actually, it seems like you have more of tidal ventilation is due to deformation of the alveoli, which is more positive than deformation of the alveolar ducts, which is the case in conventional ventilation. And this may also facilitate lung protection, even though it's a perhaps even more theoretical point of view. But also, one of my main points that I will always try to say in the beginning when I try to teach someone to use APRV, that is to simply unlearn what you know. You have to forget about stuff as the inspiratory to expiratory ratio and breathing frequency, and even positive end expiratory pressure, because those terms will not be relevant in the same way as they are for conventional ventilation. Instead, you should focus on these things. I mean, we just set the Phigh, the pressure for the CPAP phase, and we set the time high, the time spent on the high CPAP phase. So Phigh is the pressure on up here, and Thigh is the time we spend up here. And then we set Tlow, which is the pressure during the release phase. In some ventilators, they call it PEEP. And you set the Tlow, the time low, the time spent on the expiratory phase. And of course, you can think in terms of breathing frequency and IE relationship and PEEP and all that. But if you do that, you will probably end up with just a very much more complicated way of setting the ventilator to do conventional ventilation. And that's not what we aim to do. But we really want to use these settings to optimize ventilation in a specific physiological fashion that is quite different from conventional mechanical ventilation. And if we just jump into the settings, the first thing I want to talk about is setting the Phigh, the pressure on the inspiratory long plateau phase. And usually you can approximate Phigh as plateau pressure in conventional ventilation. For most patients, in my experience, we end up between 20 and 25 centimeters of water for Phigh. Some patients will require higher pressures, sometimes even above 30 centimeters of water, and those patients will almost invariably be the morbidly obese or patients that are obese and have a active inflammatory process or something going on in their abdomen that will be in practice a restrictive process in regards to the thorax. But usually for most patients, 20 to 25 centimeters of water will work just fine. And setting the Phigh in a patient without spontaneous breathing is extremely difficult. You will have to simply go from plateau pressure and sort of approximate and make an educated guess on what you think might be appropriate. But as soon as you get the patient to start breathing, and we always do encourage spontaneous breathing in APRV, but once they do breathe, you can look at the breathing, and your goal is to make the patient comfortable. They should not be using their auxiliary breathing muscles. Then you have probably set an incorrect Phigh. So when Phigh is set correctly, breathing is as comfortable as possible. And if you haven't tried this before, you will probably think that I'm insane saying that you could have 20 to 25 centimeters of PEEP, which is what you have for the most part, and just breathe comfortably. But it just works. That's the magic of it. And the goal is to, with the Phigh, achieve an adequate aeration. I mean, if you set Phigh too high, the patient will be over distended, and their compliance will worsen, and because of that, they will have a distressed breathing. And also, if you set Phigh too low, you will get de-recruitment and sort of bad compliance because of that, and you will look pretty much the same. So sometimes it's just easy to say that, well, Phigh is probably not correct. I mean, the patient doesn't look comfortable, but it's very difficult to say if you should go up or go down. And in that situation, you will simply have to make a guess, try changing it one way and reevaluate and see if it didn't work out or if it got worse, well, try to change it the other way. And you will probably end up setting it correctly eventually. Going on for time, Phigh, well, the initial setting is typically between 4 and 6 seconds for adults. And one of my main points is that for adult patients that do not have a severe airway obstruction, for example, in COPD or something like that, if you go below 4 seconds in Phigh, you're not really doing APRV, because you need to have adequate time to recruit the lung. I mean, lung recruitment is a function of pressure and time, and the time is critical. And if you shorten T-high too much, you will get de-recruitment and you will lose all of the physiological benefits of APRV, and it will simply not work out for you. So even if you have a problem with carbon dioxide elimination, and if you're forced to go below 4 seconds, you should probably consider doing something else than APRV. Children, you can go a little bit shorter because they don't have they have a shorter expiratory phase, so you can have a shorter inspiratory phase and still remain with more than 90% of the tidal cycle in T-high for children. So you can go a little bit shorter on T-high there. But for stable adults, I usually start around 5.5 seconds because you want to keep T-high as long as possible, because also it adds to the magic of being on P-high. So you want to keep it long. But if you have patients with severe respiratory or circular failure, I mean patients in shock, you might have to start with a little bit lower T-high, down to 4 seconds or just above, because if you have a short T-high, that will add more of the releases during a minute, which will give more of the convective ventilation due to the breaths that are created by the ventilator. But like I said, the aim is to keep T-high as long as possible. Going on, we always set P-low to 0. Always, without any exceptions at all, P-low is set to 0. And this is not because that I think that PEEP is irrelevant. It's because that we use the time on T-low to set an auto PEEP or intrinsic PEEP. And this is something that we don't have to quantify, because I will get back to you on how we set T-low. But my main issue is that the patient's lungs will never equilibrate to the pressure we set for P-low. If you set a P-low higher than 0, it will only add resistance on the exhalation, which will prolong the need for a P-low phase, which in turn means that you can have less time in the breathing cycle spent on P-high. And P-high is where the patient benefits. So really, you don't ever have any advantages of going above 0 in P-low or PEEP. However, Tlow, this is probably maybe the trickiest setting for many people to conceptually understand what's going on, because this is really the key to success of the treatment. If you don't, if you're not able to set Tlow, you cannot do APRV. It's as simple as that. And Tlow, in the way we use APRV, should always be set so the expiratory flow rate falls to 75% of its peak value. I'm sorry that I have been incorrect here. It should not say peak expiratory flow rate. It should simply say expiratory flow rate falls to 75% of its maximal value. That is, if you leave Tlow to go on indefinitely, expiratory flow will fall to 0, of course, and that would mean that we have 0 auto PEEP. And because we don't do that, we retain auto PEEP. The magnitude of auto PEEP is really irrelevant. We only have to look at, we don't have to measure that. We only have to look at the flow chart. And on the image here, you can see like different examples of, for example, 10% of expiratory flow would be setting Tlow, so we get expiratory flow to fall all the way down here. This is an example of 25% or 50%, and this is the way we want to set the ventilator, to 75% of peak expiratory flow. That is the exhalation. It stops when the expiratory flow falls to 75%. Typically, this means that we use a Tlow of between 0.3 and 0.7 seconds. But this is very dynamic. It needs to be reevaluated all the time, because any slight changes in compliance or resistance will lead to a different fall in expiratory flow if you don't change your Tlow. Also, sometimes it's very difficult to evaluate, because if this patient is spontaneously breathing just during the release phase, your tracing will be severely affected by this, and it's difficult to set. So you have to sort of look at the curve for a long time and try to see a release phase that is fairly unaffected by spontaneous breathing to really evaluate at that instance. And this is important, because if you set Tlow too long, so you get a sort of a higher fall in expiratory flow rate, then you will have, first of all, you will have a too large of a tidal volume, and second, you will have de-recruitment during the exhalation. And even though this will add to a higher minute ventilation, it will not improve carbon dioxide elimination, because you get the de-recruitment, and then you don't get the diffusive carbon dioxide elimination that you need. So this is an example of when you can actually, by increasing tidal volume, increase alveolar ventilation without having any positive effect on carbon dioxide elimination. So it kind of challenges our normal rules on mechanical ventilation. On the other hand, if you set Tlow too short, so you don't that the breath terminates higher or earlier than when you have fallen to 75% of peak expiratory flow, then you will have too small of a tidal volume. You will not have enough convective ventilation if the patient is relying anyway on your mechanical breaths and not just spontaneously breathing on Phigh. And that could possibly impair carbon dioxide elimination. So setting Tlow to achieve the fall to 75% of peak expiratory flow, that is really the key to setting up everything in a correct way. There's a Dräger specific function called Autorelease that will do this automatically. If you have Autorelease on your ventilator, you only set the maximally allowed time on Tlow, and then the ventilator will automatically adjust every Tlow to have a release that will be set to the desired value. But you can sort of, the 75% you can set from, you can choose whatever percentage you want, but 75% is what we usually recommend and what you should use. But you set that, and then the ventilator will terminate Tlow when you have the desired fall in expiratory flow. And this is really helpful for people that are uncomfortable with doing this, and for dynamic patients. However, it's not a substitute for knowledge, because there are some patients, especially patients with a lot of spontaneous breathing, that will interfere with the ventilator and sort of mess up the setting, and then you can, I have seen like 1 or 2 patients where this hasn't worked. So you will have carbon dioxide retention because you don't, the ventilator will falsely terminate the breath. So even though this is an excellent function for many patients and can be really helpful in the clinic, it still means that you have to know how to set this manually, because in some patients you can't trust the automated function, that you must be able to do it for yourself. But it can conceptually also help in training of people that are not too used to APRV, because you can sort of get some help to see how it differs between breaths and how the ventilator works setting a correct Tlow. If you have problems with ventilation, either hypercapnia or hypoxia, you can basically consider the same type of interventions. I mean, the first thing I usually consider is if T high is too short, because like I said before, time together with pressure facilitates recruitment, which is a hallmark of APRV, and you have to have a fully recruited and expanded lung to really get the diffusive gas exchange that we want to achieve. One of the most common problems is that T high may be set too low, so you get the releases too often, and the lung won't stabilize in a recruited way. So if you have hypercapnia or hypoxia, you may want to consider increasing T high. And I just want to state this again, that increasing T high will give you releases more seldom, which, if the patient is not spontaneously breathing, will decrease minute ventilation. But I've seen examples of patients that have actually, they've had like a U-shaped curve for carbon dioxide elimination. I mean, I remember one patient that I had on a ventilator for a week with fairly healthy lungs, but he was on APRV the whole time. And for him, the optimal T high was 5.3 seconds. If you would go lower than that, you would get de-recruitment, and the patient would, even in the context of increased minute ventilation, he would actually also increase in his carbon dioxide levels. And in the opposite way, of course, if you increased T high more than 5.3 seconds for this guy, well, the releases would come too seldom, and then he would have hypercapnia due to not enough convection. But there is like an optimum point for every patient. If you have gone above that point, well, or below that point, I mean, then you have to maybe increase T high. Also, P high is something that you can, either in hypercapnia or hypoxia, consider if it's set too low, because if you don't have enough P high, you will not recruit the lungs properly, and then you will not get the diffusive gas exchange that you need. And increasing P high may, in that circumstance, actually improve the gas exchange. I would also like to stress that P high is not anything that we set to affect tidal volume, because, and I have seen there are published protocols of APRV where P high has been used as a guide, or P high has been guided by sort of setting the tidal volume, and this is not thinking it through correctly, because the tidal volume is really set by during the release phase properly, with so that we will get the expiratory flow rate to fall to 75% of its maximum. P high will not affect tidal volume because it's totally affected by how we set T low. So P high is important for gas exchange and for setting the making breathing comfortable, so the patient is, well, simply in having the right amount of expansion of the lungs. If you still have problems, or if you're fairly sure that you don't need to increase either T high or P high, well, you have to consider if you have gone too high in either of those settings, because that is not an uncommon problem either, that we have set either P high or too high, or T high too high. And of course, if we set too high, we need to decrease. And this is in conventional ventilation. I mean, it's always obvious. If you know that the patient is not ventilated enough, well, you increase, for example, breathing frequency, and you will have a response that you can easily predict what it's going to be. In APRV, this is a little bit more difficult, because the response might be contradictory to what you were setting, and you will always have to sort of be prepared to go the other way and try and test if, okay, increasing didn't work, I'll try to decrease instead, both pressures and time. And this is just how we set it up, and something that you will get used to if you do this a lot. Also, if you have problems with hypoxia or hypercapnia, always make sure that Tlow is accurately set. I mean, we always want the flow decrease to be to 75% of peak expiratory flow rate, but if it's not there, well, we might get hypercapnia because we have too short Tlow, so we don't get enough exhalation, or we could have a too long Tlow, so we get de-recruitment during the exhalation. And like I said before, don't ever change Tlow. It's always supposed to be 0. Sorry. Well, some more general points. When we start APRV, always try to get the patient to breathe spontaneously. APRV will be working even in brain dead patients with absolutely no spontaneous breathing, but a lot of the benefits will improve in spontaneous breathing, and also it's much easier to set a correct Phigh, and spontaneous breathing will actually help to preserve cardiac function, and it will also, of course, be beneficial for to avoid atrophy of the diaphragm and stuff like that. So there are many benefits of spontaneous breathing, and we should always try to have at least 50% of the minute ventilation to be spontaneous within the first 24 hours. And your ventilator will tell you how much of the minute ventilation that is due to the ventilator-initiated mechanical breaths from the releases, and how much that is due to spontaneous breathing. Also, one of the general points of this is that we will have a very high mean airway pressure, which will lead to lung expansion and recruitment, and in this fashion also probably lung protection. And like I said before, I mean, it does sound kind of insane to breathe on a PEEP level of 20 to 25%, and also to have cardiac function in that range, but probably due to the fact that when the lungs are recruited, you will have a tremendously positive impact on the vascular resistance in the pulmonary circulation. You actually see that cardiac function is very well preserved, and I've had many patients going from mechanical ventilation to APRV that has been on different types of cardiac output monitors, and usually it works just fine. The thing that might be problematic is hypovolemia. That can have then, if the patient is severely hypovolemic, that can have a profound effect on cardiac output when you switch to APRV, and you usually have to sort of hydrate the patient first. However, you should not overhydrate. I'm not talking about hypervolemia. I'm just talking about avoiding hypovolemia. If you don't get the patient to breathe spontaneously, we can do what Phigh calls a stretch test, which is simply stretching out Phigh. You increase Phigh by 10 seconds, so you get an extremely long Phigh with very few breaths every minute, and that means that if the patient is not spontaneously breathing, he or she will quickly accumulate a lot of carbon dioxide, which will start to stress the breathing regulation, and a lot of times it will result in spontaneous breathing. But you should evaluate after 3 minutes and then return to your previous settings. And if you did not get spontaneous breathing from this maneuver, you have probably oversedated your patient and should try to decrease sedation significantly, and a while later do another stretch test and see if you can start to get them breathing. Because almost all patients will benefit from spontaneous breathing. Generally speaking, you can say that patients with healthy lungs or restrictive lung impairment, I mean, for example, ARDS patients or pneumonia patients, or many different types of patients, respond. It's fairly easy to set up APRV once you think about how you do it. The patients that are more tricky are those with airway obstruction, for example, COPD patients with severe obstructive disease. I've had some examples where APRV has performed in an excellent way in those patients as well, but it's much more difficult to set up the ventilator. And if you're not used to using APRV, you should not start on the COPD patients and train on them. But once you know how to do it, you can go on and try with obstructive patients. And the general principles then is that you shorten T high, maybe a lot. You can go as low as 3 seconds for COPD because you will still have a high mean airway pressure because there will be a fairly high pressure during the release phase that will be much longer than in conventional patients. Tlow is as always 0, and you, as in all other patients, you set Tlow to achieve a fall to 75% of the expiratory flow rate's maximum value. However, this may take like 2 or 3 seconds, and patients, at least in the acute phase, are often not quite comfortable with this because they will have a lot of carbon dioxide accumulation, and it will be they will probably not be comfortable from the beginning, at least. So these are patients that you might actually have to give muscle relaxants just to get the treatment started and the lungs expanded and so on. Once you're set up and going about with it and it's working, well, then you can try to discontinue the muscle relaxants and let the patient start breathing spontaneously. When we wean the patients, well, first of all, if you have a function for tube compensation, you should apply that with 100% compensation. So you make it as easy as possible for the patient to breathe. And then we should always, when we do APRV, aim to increase T high as much as possible. I mean, we always have to look at the patient because the longer the T high, well, the more we allow the patient to spontaneously breathe, and we sort of work on discontinuing the mechanical support. However, when the patient is sick, they will need a certain amount of support, which will be the limit of how much we can increase T high, because if you increase T high too much, the releases will come too seldom and the patient will be worn out. So how you evaluate if you give a proper support, this is very much in the same way as you look at any patient on ventilatory support. You evaluate work of breathing. If you use rapid shallow breathing index, that's something you can look at, or P 0.1, or how the patient looks, if they seem to be comfortable, or whatever way you use of evaluating a proper support. And once you feel that the patient could well, do more of the work by him or herself, then you simply increase T high in small steps up until you get to a maximum T high of 30 seconds, which actually means that you have 2 releases per minute, and in between that, simply CPAP. And for this whole time, you haven't changed P high. That is just kept at this level, usually between 20 and 25 centimeters of water. And once you're up to 30 seconds on T high, well, then you simply change to CPAP. You change the mode to CPAP, and you set PEEP equal to what you had as P high. Again, this is PEEP of 20 to 25 centimeters of water, and you don't add pressure support. You set that to 0, but you still use the tube compensation if you have that. And once you're on this position and this is working, well, then you start to decrease the CPAP pressure. And Nader Habashi, their protocol says that once they're at 15 of CPAP, 15 centimeters of water, then they do a 0 PEEP trial for 30 minutes, and if that's fine, well, then they extubate. In our institution, we usually wean a little bit longer and try to go down on lower levels, and we might add some pressure support in the end, actually, when you have a low CPAP level to sort of, it ends up being more of conventional ventilation, usually just before we extubate. But this is one way to do it. And usually it works just fine. I think I've said this a couple of times that spontaneous breathing is very important, and we try to use as little of sedation as possible to facilitate spontaneous breathing. And like I said also before, it's quite possible even to ventilate brain dead patients. And one of the key points about this is that when you start APRV on healthy lungs, you usually get an adequate gas exchange from the very beginning. So it will be fairly easy to set the ventilator to have okay oxygenation and definitely also carbon dioxide elimination. But something that may be a problem when you start using APRV on lungs that are diseased and with sick patients is that usually you will have a fairly adequate gas exchange, and usually you will quickly get good oxygenation, but it's not uncommon that you have a problem with carbon dioxide elimination in the very beginning, because it takes time for the lung to be recruited. So over the first like 12 to 24 hours, it's not uncommon with significant hypercapnia when you start APRV on sick lungs. And this is in my institution a major problem, because like almost half of our patients are neurosurgical, and of course hypercapnia is not anything we can allow in those patients, which is a severe limitation of this mode. But for any other patient, I'm usually not worried about the hypercapnia, and it will be addressed eventually. And usually you start APRV because of hypoxemia, and the effect on oxygenation is usually fairly quick. You can see for a couple of minutes perhaps that oxygenation worsens, and then the patient will quickly start to improve, and usually they improve very fast. So talking about indications, well, catastrophic hypoxia is one where you as a bridge to ECMO or trying to avoid ECMO. And that is one situation where APRV definitely has its place to simply try to get the patient to not die from hypoxemia. Also, recruitment is if you have. I had one patient that was unexpectedly admitted to our ICU from the OR, and because some kind of abdominal operation that went wrong, and the patient required a lot of oxygen. Even though they tried to recruit in the OR, they needed to give like 80% oxygen when they transported to the ICU. And so I received the patient. I had a lot of other things to do, so I just spent literally 15 seconds on setting up APRV, and then I left the patients, and I came back there 2 hours later and just to admit the patient formally. And then she was on room air because the nurse bedside had been able to just lower the oxygen continuously without changing anything else. And of course, this patient could have been recruited in any other fashion, but I'm fairly sure that I could not in any other mode spend 15 seconds to do all of the recruiting. And it's that easy if you know APRV. Also, because spontaneous breathing is totally unsynchronized, if you have patients with ventilator dysynchrony or that you need to deeply sedate to be able to sort of follow the ventilator, APRV is often a very good mode because it allows the patient to just breathe a little bit by themselves, and the ventilator will do the work regardless of what the patient is doing. So then also, of course, I think that one important indication is to learn the mode. I think that basically all patients, possibly apart from those with hypercapnia and intracranial processes, in any other situation, I'm fairly sure that APRV will not harm the patient, and it might actually benefit the patient. So just getting familiarized with the mode and training on it is definitely an indication that I feel is quite all right. And also possibly, we might see in the future, but lung injury prevention might be an issue. I mean, CanAPRV claims that they basically don't have ARDS in their institution because that they use APRV for all of their patients. Also, just quickly on COVID-19, well, basically, we have used APRV and feel that it works as with any other indication. Because APRV is very adapted to the personal situation, you don't really have to worry too much whether or not the patient has a problem with compliance or not. So in Sweden, we've had a lot of talk about the low and high elastance phenotypes and how that should affect how you set up the ventilator. But if you use APRV, you can really do it the same way, and it will work out in all situations. And it's been very effective against hypoxia in COVID-19 patients. And also, I feel that one of the benefits of APRV in these patients have been that they have a really strong drive to breathe, and it has been difficult to get them to be synchronized with the ventilator. And as I said before, that problem is just basically you don't have to worry about it in APRV. So that also is a major benefit in COVID-19. I should say that a fairly small minority of our patients have actually been treated with APRV, but we've used it in some of the more problematic ones, and we feel that outcome is really good. So we're happy that we have the mode in our, well, among the things that we can do for our patients. So quick references. The first one is CanAPRV and how they sort of described their own experiences of APRV, and a more sort of how to do it text is the second reference. The third reference is a Chinese study where they have used APRV in pretty much this fashion on ARDS patients with a very good outcome. And the final study is another text from CanAPRV with sort of a review, but also a detailed description on the mechanics and the possible benefits. But I do have to stress that there hasn't been any large multi-center randomized controlled trials, so we don't have like the scientific truth on this yet. But well, at least I'm a believer, and I would be happy to take your questions now.
Thank you, Dr. Niklas, for your great presentation and for your great insights into the APRV and some of the indications and contraindications. We already received a few questions. However, I would like to highlight till now, if you have any questions, please type them into the chat box. And we will start with the first question. Can APRV be used with paralytic agents?
Yes, it can. I would say that the main indication is for COPD patients with severe carbon dioxide retention, because they will be almost impossible in the beginning of the ventilation to ventilate without relaxants. But other than that, I really don't see the indication for like ARDS patients. I advocate that you allow the patients to breathe spontaneously, because I think that self-inflicted lung injury is not an issue in this unassisted ventilation when they just breathe spontaneously on top of the CPAP level. And I would like to stress that in conventional ventilation, I'm very much for using relaxants and avoiding self-inflicted lung injury. So I teach my residents that if you put a hypoxemic patient on non-invasive, they should immediately improve within an hour. Otherwise, they are obligated to intubate the patient. And if they cannot sedate the spontaneous breathing away in that situation, they should relax the patients. But on APRV, I do think completely different. it's also quite possible to prone patients on APRV. We've done that a lot, and it works just fine.
Thank you, Dr. Niklas. There's another question. What is your experience in COVID patients with severe ARDS?
Well, the severely hypoxemic COVID patients have responded well to APRV. I mean, we had you quickly oxygenate them much better, and also because they tend to be having a tremendous drive to breathe, you get a lot of less dysynchrony, because that has been one of our main problems in COVID. It's ventilator dysynchrony, and that is much less of an issue in APRV, because the patient, well, like I said, they can pretty much breathe independently of what the ventilator does, and it does work out fairly well.
Thank you. The next question is, how about use of APRV in COVID patients with peculiar lung compliance, depending on the different phenotypes?
Well, actually, like I said, the different phenotypes have been a big issue here for how you set up the ventilator. But in APRV, it really doesn't matter, because APRV automatically adjusts to the patient's physiology. I would like to recommend the last reference I have, the one from Annals of Intensive Care with Nader Vashi from this year, where he actually spends a lot of time talking about just how the APRV is fairly automatically individualizing itself towards the patient's needs, because of the relative setting of the release phase towards the drop to 75% of the expiratory phase. Then you have I mean, a lot of the issues about driving pressure and stuff like that is just, well, they are passed because they are automatically adjusted for in that situation. So that's one of the fantastic things about APRV, is that it adapts really to what the patient needs if you set it up in this way. That remains only setting Phigh correctly. That's really the one tricky thing that you have to think a lot about and might have problems with.
Excellent, thank you very much. I think there is a few more questions, no more for now. So there is no more questions for now. So I would like to, okay, there's one more, last minute, one more last question. So you didn't talk about the complications of ARDS. Have you experienced any specific complications with APRV?
I had barotrauma, patients with pneumothorax, for example. I've had that also I can't say that I've seen it more in APRV than in other types of conventional ventilation. It's not very common, but it's if you have, you know, in the really sick patients with really diseased lungs, it's something that happens every now and then. And we had, when we started doing APRV, we had a patient here that had a pneumothorax, and everybody was like, well, this is due to the APRV, but I'm not sure. And it's one point that I would like to make, that if you are to introduce APRV in your institution, you need to really spend a lot of time educating everyone and make sure that everybody knows how it works. And also do select the patients. I mean, if you take the patients that are most prone to have a pneumothorax, for example, well, it's a complication that might happen during mechanical ventilation, and if it happens during APRV, everybody will be sure that it's due to APRV. So do try to select the patients that you think are unlikely to have complications from the very beginning. But other than that, I mean, because that you don't have any really dysynchrony and problems like that, I think that we have a lot to gain, and I'm not more worried in APRV than in any other mode for that type of complications. The one thing that most often happens is that if you have a patient with severe hypovolemia well, then you will have a cardiac output problem. And then every now and then you have patients that you can't really get it to work on, that they, you know, they simply don't appreciate the greatness of the mode. And it's like everything else, there is no size that fits everyone. I mean, this is not going to be perfect for every patient, but a lot of times it will work out just fine.
Excellent. Thank you very much for sharing your experience. I think it was very valuable insights, and I don't think we have any more questions. So I would like to thank you, Dr. Niklas, for taking the time and going through the topic today. And I would like to thank all the participants for joining our webinar. The webinar recording will be available after the webinar on demand. So please stay tuned onto your email address. And thank you, everyone, and have a great day.
Okay, thank you.